Hello, welcome to Rheumatology Highlights. I'm Christopher Ritchlin, Professor of Medicine at the University of Rochester School of Medicine and Dentistry, and I'm going to speak to you today about highlights from the EULAR Rheumatology meeting in the area of ankylosing spondylitis. And the first slide is one of background, which reviews the ASAS criteria for diagnosis of inflammatory back pain. And I'm showing you this now because I'm going to refer back to it in the next slide. So these criteria are meant to be applied in patients with chronic back pain of more than 3 months, and they are listed as age at onset less than 40 years, insidious onset, improvement with exercise, no improvement with rest, and pain at night with improvement on getting up. And inflammatory back pain via these criteria are thought to be present if at least 4 out of 5 of the parameters are fulfilled. With this in mind, I want to move to the next slide, which looked at red flags which could help general practitioners diagnose early ankylosing spondylitis in patients with chronic low back pain. So in this particular study, they had 364 patients with chronic low back pain identified from the records of general practitioners. Their age was 19 to 45 years, and they had a mean symptom duration of 9 years, and almost half of them were male. They completed the inflammatory back pain questionnaires, and a history and physical examination was performed by a rheumatologist along with HLA-B27 allele, radiograph, and MRI of the SI joints. 21.5% of these patients with chronic low back pain had axial spondyloarthropathy, and almost 7% had AS. And you can see from below in this table the sensitivity and specificity of the IBP questionnaire, the response to NSAIDs, family history of axial SPA, and then looking at these in combination, which did yield a reasonable sensitivity, although specificity was somewhat lower. Interestingly, uveitis, enthesitis, dactylitis, psoriasis, and an elevated CRP had low sensitivity. So this study showed that a combination of the inflammatory back pain criteria, family history of SPA, and response to NSAIDs may help general practitioners to identify patients at risk for AS. And of course, this is critical since there is a widespread conception that these patients are not identified, and hence the lower prevalence in the United States and other countries. The next slide looked at the DESIR cohort of patients with early inflammatory back pain that ranged in duration from 3 months to 3 years. And you can see the mean age and gender status, as well as about almost 60% were HLA-B27 positive. There were 115 patients in this particular cohort with psoriasis. And they found that compared to the inflammatory back pain patients without psoriasis, they were similar in age and gender, B27 status, radiographic and structural changes. The psoriasis patients had higher CRP and cholesterol and triglycerides. And on ultrasound of the Achilles, the psoriasis patients had more erosions and abnormal vascularity. When looking at multivariate analysis, family history, BAS-Phe, which is a functional measure, cholesterol, and dactylitis were all associated with psoriasis. And one can see here the prevalence of dactylitis in the bar graph, 24% in psoriasis compared to 11% in those with IBP without psoriasis. Likewise, enthesitis was somewhat overrepresented in the psoriasis cohort. And again, you can see from the functional measures as well as the BASDI that the patients with psoriasis did a bit worse. So in conclusion, inflammatory back pain patients with psoriasis have more severe axial disease, enthesitis, and dactylitis. The next slide looked at whether or not smoking reduces the efficacy of TNF antagonists in ankylosing spondylitis. And so they looked at 81 AS patients treated with TNF antagonists for a year. 38% were smokers, 30% were ex-smokers, and 32% were never smokers. And you can see here that the mean baseline between current, ex, and never smokers, and they're looking at the mean baseline DASI in red compared to BASDI in red compared to the mean 12-month BASDI in green. And in this study, there was really a non-significant trend towards less response in current smokers. But it may be that this small study was simply underpowered, and you definitely are seeing this trend. So it will be important to look at a larger data set in order to clearly determine whether smoking does reduce efficacy of anti-TNF agents in AS. And we're going to see more about smoking in AS in the slides to follow. Here we have smokers with early axial spondyloarthritis have more inflammation and damage than non-smokers. So in the previous study, we saw a trend toward lack of response in TNF antagonists. In this DESIR cohort, of which we saw earlier in regards to psoriasis, 654 patients with inflammatory back pain of less than 3 years duration. You can see the criteria that these patients met, and 37% of them were current smokers. In multivariate analysis, smoking was associated with a lower health-related quality of life, and this included the ASQUAL and the SF36. If one looks at the table to the right, you can see the onset of inflammatory back pain, BASDI, function, the MSAS, which is a radiographic measure of new bone formation, and SI joint inflammation were all examined. And one can see that in the early SPA group, smoking was associated with earlier onset of inflammatory back pain, poorer functional status, and greater inflammation with also more bony progression when compared to the early SPA patients who did not smoke. In the next study, risk factors for X-ray progression in an axial spondyloarthritis group were examined in 200 patients who had radiographs at baseline and 2 years later. And this was an early spondyl cohort. 115 AS patients and 95 patients with non-radiographic spondyloarthropathy. 14% of patients had X-ray progression. It was higher in those, meaning the radiographic progression, with baseline sacroiliitis. The numbers are shown there. So if we look at the table, it shows factors associated with progression in multivariate analysis. And these included syndesma fights with an odds ratio of 4.8, elevated CRP, and smoking. Interestingly, there was no association with radiographic progression and the variables age, HLA-B27 positivity, BASDI, BASFI, peripheral arthritis, enthesitis, psoriasis, or spondy family history. So this small early RA study revealed that baseline radiographic damage, high CRP, and cigarette smoking were all predictive of spinal progression in axial spondyloarthropathy. The next study examined the risk of lymphoma in AS or psoriatic arthritis patients, and they looked at two different time points. The first time point was between 1969 and 2007, and the second was between 2001 and 2007. This particular registry had 15,000 AS patients, almost 20,000 PSA patients from the Swedish National Patient Register. Two controls were randomly identified from the general population and matched to each patient by age, gender, and residence. So in the left side of the table, you see the relative risk of lymphomas in AS and PSA patients that were observed between 1969 and 2007. And one can see from the relative risk that this is not significant. In other words, the confidence intervals all cross 1. To the right are patients who were diagnosed with lymphomas between the years 2001 and 2007. And if you look to the right in the last column, the relative risk in this group is also not significantly increased in that once again, the confidence intervals both cross 1. So in conclusion, In contrast to RA, where the risk of lymphoma has been intensely studied and found to be elevated, it does not appear that lymphoma is increased in either AS or PSA, in either the pre-TNF antagonist era or the present treatment era. In this next study, investigators examined the cardiovascular event rate in ankylosing spondylitis. There have been a number of abstracts over the last year, both at the last year EULAR meeting, ACR, and now regarding the risk of cardiovascular disease in AS. Indeed, one study presented at the EULAR last year suggested only those patients with active AS were at increased risk of developing cardiovascular problems. In this study, 286 patients were prospectively enrolled in a cohort and followed for 2 years. You can see the demographics that are listed on the slide. Almost half the patients were on antihypertensives, about a quarter on statins, and almost 10% were taking diabetes medications. A very high degree of NSAID use in this group. Small number of patients on TNF antagonists. 4.4% of the patients had an incident cardiovascular event, and a majority of these were first-ever events. And what you can see in the table below, which shows the cardiovascular event rate per 1,000 patient years, comparing all AS with men with AS, women with AS in the general population, is that the overall cardiovascular event rate in all AS patients was 22.3 compared to the general population, which was 15.1. And you can see that the rate of men with AS in terms of cardiovascular events is quite a bit higher than that with women. So it would appear from this study that cardiovascular events appear to be increased. We have to think about this when we're taking care of our patients with ankylosing spondylitis. Similar to kinds of thoughts need to be central to our care of patients with RA and psoriatic arthritis, where these risks are increased as well. An important question that's been put before rheumatologists is whether or not non-steroidal anti-inflammatory medications can decrease pathologic new bone formation in spondyloarthritis. This novel study examined the bony progression in patients with axial SPA who were on non-steroidal anti-inflammatory medications. They chose 181 TNF antagonist naive patients who had radiographs at baseline and 2 years. 100 of these patients had less than 10 years, and 81 were non-radiographic axial spondyloarthropathy, less than 5 years. And patients were assigned to an NSAID intake index of 0 to 100, which was considered high intake if over 2 years was equals 2 years greater than 50. The table shows the progression by the ASAS in both low NSAID users on the left and high NSAID users on the right, and one sees that a change in MSAS is significantly elevated in the patients, significantly decreased. In other words, the degree of bony progression is significantly decreased in the patients who had high versus low NSAID intake. And you can see this in both AS and in axial SPA. So in this small study, high NSAID intake over a 2-year period was associated with lower radiographic spinal progression in AS patients. These data are very intriguing and accentuate the idea that PGE2 is an important mediator of new bone formation, and more additional studies will be needed to confirm these intriguing findings. In the next abstract, the group from Edmonton, Canada, wanted to try and better understand the mechanisms that underlie new bone formation in ankylosing spondylitis. And they identified these chronic inflammatory lesions, or coronary inflammatory lesions. And coronary inflammatory lesions can be either acute, type A, or chronic, type B. The type A tend to be what we consider osteitis and have a high signal on MRI, whereas the chronic type B have a low free water signal. And a cartoon at the left illustrates how the progression of these lesions is thought to occur in the setting of TNF antagonist therapy. So you have these chronic corner inflammatory lesions as shown on the cartoon, and these are identified, of course, by MRI. And treatment of TNF antagonists can result in these lesions either undergoing a change to a fatty infiltrative phenotype or a complete resolution of the changes that were seen prior to treatment with anti-TNF. So a normalization of the bone from an imaging standpoint. Once patients develop these fatty corner lesions, they can go on to develop new bone formation and show syndesmophytes or have complete resolution. So what they asked in this study is what MRI findings correlate with new bone formation. And they had MRIs in 76 AS patients randomized to either adalimumab or placebo, and these MRIs were taken at baseline, week 12 and 52, and X-rays were taken at baseline in week 104. And they found both acute and chronic corner inflammatory lesions in 12.5 and 3.6% of the lesions, and new bone formation was associated with these chronic corner inflammatory lesions and fat. Interestingly, these lesions of new bone formation, associated with new bone formation and chronic corner inflammatory lesions, seem to occur whether or not they resolve, but none resolve in acute lesions. So, but none were seen in the acute lesions that had resolved. So, looking back over to our cartoon, you see the chronic corner inflammatory lesions, TNF therapy. You can either go to fat or resolution. And we see that fatty lesions can either go to bony formation or resolution, but also those chronic lesions that have resolved, and the arrow is not shown there, can then go on, at least in some of them, to go on to form new bone formation and not stay completely resolved. So therefore, new bone formation is most likely to originate at sites of complex lesions or fat infiltration in AS. So further studies will be needed to confirm these interesting results and help us to prognosticate from MRI findings which patients are likely to run into problems down the line. In this poster, periostin levels are correlated with new bone formation in AS. This was actually an oral presentation. Periostin is a secreted protein synthesized by mesenchymal cells, and it maintains osteoblast homeostasis. As shown in this particular radiograph, it's elevated in patients with medial tibial stress syndrome and is thought to be important in this bony repair process. In this study, periostin levels were examined in 97 AS patients who had radiographs at baseline at 2 years. With ankylosing spondylitis patients of more than 5 years, the levels were 123 picograms per mil, versus those who had a short duration, it was 77 picograms per mil, with the standard deviations as shown. 79 patients with no progression had lower levels of periostin than progressors, and you can see the numbers there, which were significant. Thus, periostin serum levels are low in non-progressors and may serve as a surrogate marker of new bone formation. The role of IL-17 in spondyloarthropathies is becoming better understood. But in this study, investigators sought to understand the contribution of mast cells to synovial inflammation in spondyloarthritis. They looked in the joints of 80 spondyloarthropathy and 50 RA synovial tissues, joints, and they looked at these histologically. And they looked at analysis of paired samples both before and after treatment with TNF antagonists in a subgroup. They found that mast cells were significantly increased in spondyloarthropathy, but not RA, and not degranulated. The mast cells express more IL-17 than RA, and this was the major IL-17 producing population, not T lymphocytes and not Th17 cells. They found that in vitro exposure of these mast cells to imatinib decreased IL-17, but TNF antagonists had no effect on mast cell numbers or IL-17 expression. Thus, a selective increase of IL-17 mast cells was noted in the synovial tissues of spondyloarthritis, and these cells were not affected by TNF antagonists. This is a surprise because mast cells, of course, are part of the innate immune system, and one would have thought that Th17 cells would have been a major population that released IL-17. Similar findings were published by Dr. McInnes in Journal of Immunology and Rheumatoid Synovium last year, but the findings here will have to be confirmed. In the next study, alendronate was evaluated for its efficacy in ankylosing spondylitis. And if you recall, Dr. Maksinovich and colleagues in Edmonton showed that there was some efficacy of pamidronate in ankylosing spondylitis. In this study, active AS patients were randomized to receive alendronate 70 milligrams per week or placebo for 2 years. And you can see the number of patients that completed the study, and you can see the outcomes that they looked at. They did find that no outcomes were seen to differ between alendronate and placebo. So on the left is the BATH-AS global score, and you can see there's not a significant difference between the placebo and the patients that received alendronate. And to the right is the ASAS 20, and once again, no significant difference. So from this small pilot study, there's no evidence that alendronate is effective in ankylosing spondylitis. In this study, a small series of patients who were refractory to anti-TNF agents and had Axial SPA were treated with abatacept. All had failed 3 anti-TNF agents, and the response that they looked at was that greater than or equal to a 20% decrease in the BASDI. And you can see here that we have non-responders, possible responders, and responders. And the mean BASDI in this group was unchanged on abatacept. Thus, from this pilot study, there seems to be limited efficacy of abatacept in TNF refractory axial SPA, which today is a very challenging population, and we have a great unmet need for trying to find therapies for those patients who are either inadequate responders or cannot take anti-TNF agents. So this concludes the presentation on ankylosing spondylitis, and I want to thank you for your attention.